Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the neurology, that is the subarachnoid hemorrhage. So, how will be the clinical presentation of a patient with subarachnoid hemorrhage? I'll just show you one small clinical scenario. So, I have a patient, she is a 52-year-old woman, right? She presented to the office where she complains that she develops the sudden onset severe headache, and on examination there is neck stiffness, and she also complains of photophobia and as well as the loss of consciousness. She awakens within an hour that she arrived in the hospital. She is noted to have severe headache, nuchal rigidity, photophobia and temperature of 38.5 degrees centigrade. So this is how the presentation of a patient with the subarachnoid hemorrhage will be. So now what is this particular subarachnoid hemorrhage? Subarachnoid hemorrhage is that where there is accumulation of the blood, right? Where there is sudden onset of bleeding into the subarachnoid space. Right, sudden onset of bleeding into the subarachnoid space. That is what is called as the subarachnoid hemorrhage. And you can see that these are all the various places where the brain hemorrhage can be. If it is present above the dura mater, it is called epidural hematoma. If it is present below the dura mater, it is called subdural hematoma. And if it is present beneath the subarachnoid space, that is called subarachnoid hemorrhage. And if the bleed, if it is within the parenchyma, that we call it as the intracerebral or intraparenchymal hemorrhage. So this subarachnoid hemorrhage, it is the disorder where there is sudden onset of bleeding into the subarachnoid space. Now, what is the etiology of the subarachnoid hemorrhage? The subarachnoid hemorrhage, it constitutes 5 to 10% of stroke. Right, it constitutes 5 to 10% of stroke. Okay, so 5 to 10% of the hemorrhagic stroke is mainly due to subarachnoid hemorrhage. And the most common cause, right, the most common cause of subarachnoid hemorrhage will be the trauma. Right, most common cause of the subarachnoid hemorrhage will be the trauma. And the prognosis of these individuals who have developed subarachnoid hemorrhage secondary to trauma completely depends upon the severity of the head injury. Right, so prognosis completely depends upon completely depends upon the severity of the head injury. And the another important etiology which will cause the subarachnoid hemorrhage will be the rupture of the berry aneurysms. Right, so these are the berry aneurysms. So what are berry aneurysms? First of all, these are the aneurysms originating from Circle of Willis. Right, berry aneurysms are the aneurysms which are originating from the Circle of Willis. Now, what is the most common site for the berry aneurysm? And what will be the shape of these particular aneurysms? These particular aneurysms, they can be saccular or fusiform. Right, they can be saccular or fusiform, and most commonly around the Circle of Willis. That is what is your berry aneurysm. And what is the most common site for the berry aneurysm? The most common site of berry aneurysm is at the junction of anterior cerebral artery and anterior communicating artery. Right, that is at the junction of anterior cerebral artery and as well as the anterior communicating artery. That will be the most common site for the Berry aneurysms. And these patients with the Berry aneurysms, they are associated with polycystic kidney disease. Right, they are associated with polycystic kidney disease. And these patients with Ehlers-Danlos syndrome, EDS, which is a connective tissue disorder. Patients with Ehlers-Danlos syndrome, they also develop this particular Berry aneurysms. Okay, so this will be rupture of this Berry aneurysms can cause the subarachnoid hemorrhage. So these are the two important etiologies. One is head trauma, the other one is rupture of the Berry aneurysms. Now, what will be the classical clinical feature in patients with subarachnoid hemorrhage? The classical clinical feature in subarachnoid hemorrhage is sudden onset of severe headache. Right, sudden onset of severe headache. That is the hallmark of the subarachnoid hemorrhage. Now, what are the other features of subarachnoid hemorrhage? One is sudden onset severe headache. The other features include loss of consciousness. Right, the other features include loss of consciousness. And this particular loss of consciousness, that is due to sudden rise in the intracranial pressure. Right, that is due to sudden rise in the intracranial pressure. So this particular loss of consciousness, it is seen in up to 50% of patients. Now, apart from this loss of consciousness, focal neurological deficits. These focal neurological deficits are seen in up to 30% of patients. Right, focal neurological deficits, they are seen in up to 30% of patients. And these focal neurological symptoms, most commonly they occur from compression of the oculomotor cranial nerve. Right, they occur from compression of third cranial nerve. That is why the individual will, this will be the manifestation of focal neurological symptoms. That is the compression of the oculomotor, the cranial nerve. Next, now there is also development of the clinical features due to pressure of the bleed dissecting into the surrounding tissues. Right, the clinical features due to pressure of the bleed dissecting into the surrounding tissues. Now, what will be those features? Due to pressure of the bleed dissecting into the surrounding structures, the individual can develop or the individual will develop photophobia. There can be also development of headache. There can be also development of nuchal rigidity, and there is also papilledema. So papilledema, it is the swelling of the optic disc, and this particular papilledema, that is swelling of the optic disc, that is mainly due to raised intracranial pressure. And this particular nuchal rigidity, that is due to meningeal irritation. Right, that is due to meningeal irritation. So these are the clinical features due to the pressure of the bleed dissecting into the surrounding tissues. Now these patients with subarachnoid hemorrhage, they also develop the fever. So fever, it is seen 3 to 4 days after the initial hemorrhage. Right, 3 to 4 days after the initial hemorrhage, there is development of fever. And if there is development of fever, this can stimulate the meningitis. Right, this can stimulate meningitis because in patients with meningitis you will have the fever. Now, why in patients with subarachnoid hemorrhage there is fever? The presence of the blood in the subarachnoid space will irritate the meninges, will cause what is called chemical meningitis. Right, will cause what is called chemical meningitis. And this particular chemical meningitis, it is from irritation by the blood. Right, it is from irritation by the blood. That is the reason why the individuals will have the fever. Right, the fever, it is 3 to 4 days after the initial hemorrhage, there is development of fever. And another important feature is the development of seizures. Seizures, they are extremely common in patients with subarachnoid hemorrhage. And whenever the individual develops seizures, 1 year mortality right, 1 year mortality, it can be up to 50%. Right, 1 year mortality can be up to 50%. With half of the patients dying upon immediate occurrence of the bleed. That is about the seizures. Right. So these are the clinical features that you will come across in patients with the subarachnoid hemorrhage. Number one, the severe headache, and the other features include loss of consciousness. This loss of consciousness is seen in 50% of patients, and focal neurological deficit is seen in more than 30% of individuals, and most commonly from the compression of the oculomotor nerve. And other features due to the pressure of the blood dissecting into the surrounding tissues include nuchal rigidity, photophobia, headache, papilledema, and all these can be due to meningeal irritation. And this fever is mainly due to the development of chemical meningitis. Seizure, it is also extremely common, and 1 year mortality can be up to 50%. Followed by that, what are the long-term complications of the subarachnoid hemorrhage? Long-term complications of the subarachnoid hemorrhage include the development of the focal neurological deficit, development of seizures. There can be also rebleeding, and another important complication is hydrocephalus. So, why do they develop this focal neurological deficit? That is, when the bleed is expanding, the expanding bleed will compress the brain parenchyma, and that will cause the focal neurological deficit. Next, and the other reason why there can be focal neurological deficit is due to vasospasm. See, whenever the subarachnoid hemorrhage occurs due to rupture of the vessels, the compensatory mechanism that develops in the other vessels is vasospasm. So other vessels, they try to undergo vasospasm in order to see that the bleed from the ruptured site is reduced. But whenever the vasospasm occurs as a compensatory mechanism, that will result in hypoperfusion. Right, that will result in hypoperfusion. And this particular hypoperfusion to portions of the brain parenchyma right, hypoperfusion to the portions of the brain parenchyma will result in the development of stroke, right, will result in the development of stroke. Now, the another important long-term complication is the rebleeding. Rebleeding occurs when the clot falls off from the original site of bleeding. See, wherever there is original site of bleeding, that original site of bleeding will get sealed off. Right, will get sealed off with the clot. And whenever this particular clot, it falls off, right, whenever this particular clot falls off, then there will be chance of development of rebleeding. Now, coming on to the hydrocephalus. See, hydrocephalus occurs when blood cells clog upon the arachnoid granulations. Okay, so when the blood cells clog upon arachnoid granulations, then what happens is absorption of the CSF does not occur, right? Absorption of the cerebrospinal fluid does not occur. So, once the absorption of the cerebrospinal fluid does not occur, there will be accumulation of the CSF resulting in the development of hydrocephalus. So, long-term complications include the development of focal deficit due to vasospasm, seizures, rebleeding that is due to fall of the sealed clot, and then hydrocephalus. So, these are the long-term complications of the subarachnoid hemorrhage. Now, coming on to the investigations. The first line investigation will be the computed tomography. Right, CT scan is the first line investigation. That will be the initial test, that is the CT brain. Even contrast is also not required. Right, even contrast is not required. Okay, and the CT scan which is being done without contrast, this has the sensitivity of 90 to 95%. Right, this has sensitivity of 90 to 95%. And this sensitivity of 90 to 95% is seen within first 24 hours after the onset of bleed. And so this is seen within 24 hours. And as the time progresses, right, as the time progresses, the sensitivity of the CT scan diminishes. Right, the sensitivity of the CT scan diminishes. Why? Why does the sensitivity of the CT scan diminishes? Because the red cells within the CSF will hemolyze and are absorbed, and they are converted into yellowish color. Okay, the RBC in the CSF they get hemolyzed and they are reabsorbed. And this RBC which has been hemolyzed within the CSF, that is being converted into an yellowish color. Right, that is being converted into an yellowish color. And this yellowish color within the CSF, that is called as, right, that is called as Xanthochromia. right? So that is about the CT scan image and as well as the sensitivity. In fact, CT brain, it is more sensitive than compared to that of MRI for the diagnosis of the subarachnoid hemorrhage, right? So this is the CT scan with the presence of subarachnoid hemorrhage within the sylvian fissure, right, within the sylvian fissure. And that subarachnoid hemorrhage, it will be in the form of a hyperdense signal, right, that will be in the form of hyperdense signal. Next, followed by that, for suppose if the initial CT is normal and subarachnoid hemorrhage is still suspected, then what is the next step? Right, if the initial CT is normal and subarachnoid hemorrhage is still suspected, then what is the next step? If the initial CT is normal and subarachnoid hemorrhage is still suspected, then you need to do a lumbar puncture. Right, you need to do a lumbar puncture. Lumbar puncture is most sensitive diagnostic test. Right, it is the most sensitive diagnostic test. And in the CSF, you will observe the presence of xanthochromia. Right, you will observe the presence of xanthochromia. And why does this xanthochromia occurs? This particular xanthochromia occurs due to lysis of the RBC. Right, that is due to lysis of RBC. Okay, and not only, and after the lysis of RBC, there is formation of the bilirubin. Right, so that is nothing but yellow colored CSF. Okay, so xanthochromia, it needs almost like 4 to 6 hours to develop. Right, it needs 4 to 6 hours to develop. So the initial CT is normal, but still you are suspecting subarachnoid hemorrhage, then you have to do the lumbar puncture. Then what is the use of the angiography in patients with subarachnoid hemorrhage? Angiography is used to determine the specific anatomic site of the vascular defect. Right, specific anatomic site of specific anatomic site of the vascular defect. And it will also shows you where is the site of bleed. Right, it also shows you where is the site of bleed. That is what is the use of the angiography. Now, in patients with subarachnoid hemorrhage, you also will observe the changes in the ECG. Right, you also have the ECG abnormalities. And that ECG abnormalities will be in the form of inverted or enlarged T waves. Right, inverted or enlarged T waves. And these inverted or enlarged T waves are often associated with the development of subarachnoid hemorrhage and are not a cause of the alarm, right? So these inverted or enlarged T waves, they are the sign of, right, they are the sign of raised intracranial pressure. And this particular T wave inversion is not just seen only in patients with raised intracranial pressure. This inverted T waves are also seen in patients with acute MI. Right, in acute MI actually the earliest change is tall T wave, but as the time progresses the T wave will get inverted. Then in patients with hypertrophic cardiomyopathy you will have inverted T wave. Then in patients with stress cardiomyopathy, you have the inverted T wave. So these are the ECG changes that you will have in patients with subarachnoid hemorrhage. Now, what is the treatment in patients with subarachnoid hemorrhage? First of all, what is the blood pressure that has to be maintained in subarachnoid hemorrhage? See, you have to take the initial steps to maintain the systolic blood pressure of to maintain the systolic blood pressure of 110 to 160 millimeters of mercury. That should be the target blood pressure. And if you pressure higher than this, pressure higher than this will provoke more bleeding. Pressure higher than this will provoke more bleeding, whereas pressure lesser than this pressure lesser than this can provoke cerebral ischemia. Can provoke cerebral ischemia by hypoperfusion. That is about the treatment of the subarachnoid hemorrhage. So, initial steps are to maintain the systolic blood pressure of 110 to 160 millimeters of mercury, and pressure higher than that can provoke more bleeding, while pressure lower than this can provoke cerebral ischemia through hypoperfusion. Now, after having said about this blood pressure, you need to know what is the surgical intervention in subarachnoid hemorrhage. See, you need to do an angiography. Now, what is the purpose of doing the angiography? The purpose of doing angiography is to determine the anatomic site that will need catheter or surgical correction. So, angiography will show you the anatomic site that will need catheter or the surgical correction. And it is important to perform angiography so that surgical correction can occur before the rebleeding develops. And how is this surgical correction done? Once you make out the anatomic site of bleed, you have to do the surgical correction of the anatomical site with embolization. With embolization or clipping. With embolization or clipping of the AV malformation. But please remember, this particular embolization is superior than surgical clipping in the treatment of the subarachnoid hemorrhage. Then, followed by that, how do you manage this vasospasm? See, why does this vasospasm occurs? It is uncertain, but we consider it to be a compensatory phenomenon. But because of this vasospasm, the individual develops cerebral ischemia and cerebral infarction, and there is development of focal neurological deficit. So, how will you diagnose that there is development of vasospasm? That is by transcranial Doppler ultrasound. Transcranial Doppler ultrasonography may be used to screen non-invasively is there any development of vasospasm or not. But conventional angiography, conventional angiography is being done. And why is this conventional angiography done? Conventional angiography or arteriography is required to document and treat vasospasm when the clinical suspicion is high. That is about the vasospasm. So, vasospasm, it develops as a compensatory phenomenon due to which the individual will develop focal neurological deficit. And you have to do a transcranial Doppler ultrasound to detect the development of vasospasm. And conventional arteriography is required to document and treat vasospasm when the clinical suspicion is high. Then how will you treat this particular vasospasm is by giving nimodipine. Nimodipine has been shown to reduce the incidence of the ischemic deficits. Right, so this will reduce the incidence of will reduce the incidence of the ischemic deficits. And what is the dosage of this nimodipine? This has to be given as 60 milligrams every 4 hours. Right, 60 milligrams every 4 hours. And the route of administration is oral route of administration, and you have to give for 21 days. And it is given prophylactically to all the patients with the subarachnoid hemorrhage. Okay, so that is about the role of the nimodipine. And the surgical correction of this vasospasm is by transluminal balloon angioplasty. Okay, surgical correction if you want to do for this vasospasm, what you have to do is transluminal balloon angioplasty. Right, so that is the treatment of vasospasm. One is nimodipine and the other one is transluminal balloon angioplasty. Now, what is the indication of the ventriculoperitoneal shunt? Indication of ventriculoperitoneal shunt is when there is development of hydrocephalus. So, if hydrocephalus occurs, then shunting will be needed. That is the indication of the ventriculoperitoneal shunt. Then, another important complication of subarachnoid hemorrhage is renal salt wasting. And this renal salt wasting is another complication of subarachnoid hemorrhage. And this renal salt wasting may develop abruptly during the first several days of hospitalization. Right, this will develop abruptly during first several days of hospitalization. So, because of this renal salt wasting, there is development of hyponatremia. Right, there is development of hyponatremia. And once there is hyponatremia, the consequence is the development of the cerebral edema. So, once there is development of cerebral edema, that will further exacerbate the intracranial pressure. And this will require carefully titrated treatment with oral sodium chloride. So, whenever there is development of hyponatremia, you need to give oral sodium chloride. Okay, or you need to give intravenous hypertonic saline. right? So hypertonic saline is nothing but 3% sodium chloride. So that is about the renal salt wasting. This is another complication of the subarachnoid hemorrhage. So the individual develops hyponatremia. Secondary to hyponatremia, there is development of cerebral edema, and this may exacerbate the intracranial hypertension, and this will require titrated treatment with oral sodium chloride, and intravenous hypertonic sodium solution should be given. Next, the next one is hypopituitarism. That is another important complication of subarachnoid hemorrhage. So these are the late complications, and whenever the individual develops hypopituitarism, the first important drug that you need to give is the steroid. So this is about your subarachnoid hemorrhage. So subarachnoid hemorrhage, it contributes to almost 5 to 10% of the hemorrhagic stroke. And this subarachnoid hemorrhage, most common cause will be head trauma. Second important cause will be rupture of the aneurysm. And the most important symptom is severe headache. The other features include the nuchal rigidity. There can be development of fever, seizures, and focal neurological deficit. And investigation of choice will be the CT scan, non-contrast CT scan, that is more sensitive than compared to that of MRI. The treatment is that you need to maintain the blood pressure of nearly around 110 to 130 or 140 millimeters of mercury, and you need to do cerebral angiography in order to make out where exactly is the site of bleed, by which you will be able to do the embolization or the clipping. And the long-term complications include vasospasm, due to which there will be new focal neurological deficit. There can be development of seizures. There can be development of the hydrocephalus. Vasospasm you can treat by giving nimodipine, and hydrocephalus you need to put a ventriculoperitoneal shunt. This completes the discussion of this very important topic, that is subarachnoid hemorrhage. Thank you very much.